Welcome back to our next session here at the Interoperability Virtual Day. This next session will be a conversation on how will interoperability further transform the future of care. As I discussed earlier this morning, if you have any questions for our faculty today, please utilize the chat functionality within the Zoom platform. I want to thank our friends at Orion Health for partnering with us on this next session. And at this time, I would love to once again welcome back our editor-in-chief, Mark Haglin, who will be moderating this session. So Mark, the floor is yours.
Thank you so much, Matt. Thank you to everyone in our audience. It's my pleasure to welcome Dr. Chris Hobson, who's the Chief Medical Officer at Orion Health. Before we plunge into our session, Dr. Hobson, why don't you tell us just a little bit about yourself personally, and then about your role and about Orion Health.
Thank you. Thank you, Mark. It's a great pleasure to be here. Personally, well, I have a wife, 3 kids, 2 grandchildren, a dog. I like cycling, but a lot of the time, I guess the motivation for getting into this particular line of work has always been working as a physician. You see the problems that we face, and I firmly believe if we can get the technology right, we can actually make life easier for the physicians. So I spent 16 years as a hospital physician in primary care in New Zealand. Right from the start, there's always been a little bit of a dissonance between all the wonderful things you learn at medical school, and then you hit the front lines, and my God, there's 10 things going on at once, and you're really under pressure. So yeah, I've worked with Orion now for just about 20 years. I've worked Asia Pacific, most of the time is in US and Canada, but also globally. The best part from my perspective is I get to see different health systems and see how people have been challenged and how they've solved their challenges. So in conclusion, I do read healthcare innovation, and I think you guys are doing a great job. So let's see if we can solve some problems today.
Well, thank you. Thank you so much, Dr. Hobson. It's great to have you. I just will say on a personal, I think it's wonderful whenever clinicians, whether physicians or nurses, get involved in this work. We really need you to help contribute your skills and your knowledge and your talents to innovating in healthcare. We've got a lot of issues to resolve. Oh, yeah. so thank you so much, Doctor. So let's talk about the idea of competing models for health information exchange. There's so many, and there's so many different ways in which HIEs operate. Is that helpful, or are there ways in which it's impeding progress?
So as a rule, we like competition. Competition is a good thing. It makes us strive to do better. And so as a principal, we're very happy working in a competitive market and so on. And the US, of course, is highly competitive compared to other countries. There are different actual companies, for instance, and then there's actually different models for an HIE. So in terms of models of what constitutes an HIE, we see things like exchange of direct secure messages. It's really just replacing the fax machine, but it's still something. We see the EHR, both the large vendors and the smaller vendors saying, well, we comply with some of the standards or most of the standards, so you can just put your data in here. And that model has a lot of appeal, especially to hospitals and large enterprises. And then more how we've always conceived it, which is the ability to take data from almost anywhere in any shape or form. So not tied down to one particular model or other. So I think it's good. I think in the end, though, competition does have to be managed to some extent. So one of our statewide clients, they had their own HIE, but there were many other HIEs or, emergency department exchanges. And what happened for a long time, the competition was actually there was too much competition and not enough cooperation. So the Department of Health said, okay, enough. We want, as the Department of Health, want to see this HIE giving health benefits back to the state. So here's how it's going to be. Orion will run the HIE. The other versions will all work with Orion, and we will have one big happy family. And actually, it has worked very well. So it can be overcome. Needs that.
Yeah. When you look at how HIE models are evolving right now in this landscape, kind of what's your 30,000 feet up view of how well, or maybe not well, things are evolving forward overall?
I think they're evolving forward pretty well. Doesn't mean that the next steps are going to be easy, but I think things are evolving well. Why do I think that? Well, the pressure of COVID pushed a lot of use of automation. So that really helped. I mean, at the start, we had customers saying, I don't care whether it works or not. We're desperate, just give it to us and we'll figure it out. Now, customers never said that before. So that gave it a big push, and that's a good thing. The other thing is, so from my perspective, from a clinician perspective, there's a good number of studies show that clinician and general usage of HIEs is steadily improving. It's a bit slow. You'll see figures like 1/3 of a hospital emergency department, 1/3 of the visits they looked in the HIE. But those numbers are going up, and we see basically people are happy, people deriving value. A couple of weeks ago, a nurse I was talking to, she said, she's talking about different things. She said, well, when it comes to the HIE, the physicians go there first. And I said, oh, that's interesting. She said, well, the data's really good. So in the end, from a clinical perspective, if I can get high reliability, high trust data, that's where I'm going to go. So I think things are improving. I think, again, 30,000 foot, there was like 100 HIEs across the US. I think we're kind of steadying down to 50 or 60, which is probably about the right number.
Yeah, absolutely. Well, and those that are surviving are really showing their value in multiple ways. They're having to survive on their own. As you know, of course, I know you know the history of this, that initially there was a lot of federal and state funding, and then all that eventually dried up. And so the organizations that have survived and are thriving are the ones that can offer value that people will pay.
That's right. Basically. Absolutely.
Well, let's talk a little bit about policy. How do you think the 21st Century Cures Act will drive change and hopefully innovation in the HIE sector and drive greater interoperability? What's your perspective on that?
So we, as a rule, again, we like the TEFCA and the 21st Century Cures Act and the things that it's pushing the market to do. If we look at a few different aspects to that. So for instance, one, there's the emphasis on FHIR APIs. And so that's a good thing. That is an ideal mechanism for which, and it's patient-centric exchange of patient-centric data. It empowers patients. There's the payer-to-payer exchange and so on. These are really good things. Just to give you a little bit more, the reality for us when we have to integrate, say in a region, say a statewide HIE or something like that, some places, some vendors, some systems are just not ready for, they can do HL7 V2 and that's about all they can do. So on that front, so we have always built the ability to handle all of those different things. So from HL7 V2 through to FHIR and all the things in between, because pragmatically that's what you needed to get the data from all these different sources. The information blocking rules and the requirement to exchange US CDI data, if that works, that will give the industry a big push forward, and we're very supportive of that. I guess it will be the laggards, the ones that are too busy with other things, maybe in poorer areas where they're overloaded. It's going to be harder for them to keep up. Second thing to talk about here is TEFCA. So that trusted exchange
Yes.
framework and common agreement. So again, we like it as an overall effect. And that one, we really like it. There's the concept of a QHIN. So you're going from being a health information network to being a qualified health information network.
Right.
So we like that. The ability to move data between HIEs because of the standards, we like that. I saw the other day that ONC is saying come 22, they're going to move to that next stage with TEFCA.
Yeah.
So we see it as a positive. And giving those kind of standards, it helps us reduce the number of times we have to do non-standard things. That's probably, from our perspective, client wants a health information network across a region. Some of them won't be up to speed. So the fewer of those, the better for us, and the more we can do standardized.
Right. No, I understand.
So
Right. I mean, I think one of the interesting things that you bring up, Dr. Hobson, is that we've got perhaps too many models. It's not so much whether some are good or even bad, it's too many, right?
That's right. And so having many models, you will pick up on the strengths and weaknesses of the different models. So that's good. But as I was saying to the Department of Health in our statewide example, you know, and perish the thought in the United States, but actually the government does have to play a role where they say, look, this is making sense, this is working, this is not, here's some good baseline standards to follow. I think ONC and CMS are hitting that. I think they're hitting the right note. So
as we shift as an industry from volume to value, as
Yep.
we move into value-based contracting for federal, state, and private payer contracts, more and more information and data are needed. How will this ongoing evolution affect interoperability?
the move from volume to value. Yeah. So we have several stories of customers who said things like, we want you to move to value, say a payer group who wants their provider partners to move to value-based care. And the totally sensible provider response is, well, we can do value-based care if we have the data.
Yeah.
You just can't do it without the data, and it needs to be fairly complete because you're going to be looking for the quality of care and so on. I think another point of reference is if you look at the HIMSS definition of interoperability, it talks about not only in the care of the individual patient, but also for the benefit of the population. So interoperability is there because suddenly you've got a view of that, almost that entire population, then you can do population health. So yeah, so our ACO clients often start with the HIE as one of their key enabling bedrock things they just recognize they need.
Yeah. A related question, how is the increase in patient-generated health data and the increased focus on population health management, how do those fit into this overall picture?
Right. So patient-generated data, so we're moving well down that track. There's stuff from devices, so you can connect the patient to their devices and their blood glucoses come in. So devices, remote monitoring. There's asking patients to submit anything from questionnaires, assessments, through to what the patient's perspective is on their care plan, so that everybody else knows, you know, how the patient is adjusting to what's going on. So there's the patient kind of their writings, their content that they want to get across. That's patient-generated data. The challenge we have, but it's more theoretical because so far it's all fine, but the concern is if we have thousands of devices from millions of patients, we may get a complete data overload. And we do have to, where we've reached at the moment is the patient-generated data is available for physicians and clinicians to view, and it becomes part of the official record if they want to, say, take that piece and put it in the official record. So you have the official record and then the patient's record. For population health, yeah, what our approach to the population health is to take each individual patient and build that up. So we've got complete information for each individual patient, and then you aggregate tens of thousands of patients. Now, one of the biggest things that's come with that, unfortunately, we've had the Googles and Apples and the very large companies. I don't mean to single out those two specifically, but they come along and they say, give us anonymized 5 million or 50 million records, and it's all anonymized. We'll run the data over it, run the algorithms, and somehow we'll give you the answer. And I think they've realized that doesn't work very well. So from our perspective, we've got each individual patient, and the data's properly privacy controlled.
Mhm.
It's identifiable, but it's all within the boundaries that we've had to meet for the HIE in the first place, the HIPAA and the local state laws and so on. So now we have a smaller but very well organized population, and that's ideal for things like value-based care.
Yeah, absolutely. I think one of the things that I know you know this, Doctor, that's been so interesting is we're trying to push forward into the era of AI, of artificial intelligence. But in some cases, there have been failed experiments in AI because it's just been kind of gigantic blobs of data. And as you know, as a clinician, that doesn't really do. There was a well-known vendor whose name I definitely shall not name here, and they tried in the radiology space, diagnostics, to do that. They spent a few years just kind of literally throwing millions of data points into a data lake, and then hoping to create algorithms out of that. And they found out that clinically, it didn't really make any sense.
That's right.
It did in theory, like, oh, this sounds really great, but in practice, it was not helpful. So one of the things that supports the HIE concept is that that the HIEs are facilitating the sharing of data, that is, they're curating data in a way that is specific enough to be useful in patient care.
Yes.
How do you see that element playing out in the next few years as we move towards all this anti-information blocking, all all this transparency?
Yeah. So you're absolutely right that as we get more and more data into the record, one of our key jobs is to take that data, curate it, and provide it back to the clinician or a care coordinator or even a social worker or whoever, but to curate it back to them so it's high quality, they understand what it means, it's easy to use and find and search, and it adds value to their clinical care of the patient. It's very interesting on the machine learning and the AI, and we have a large project in-house. We're doing a lot of work on that front. There are some well-recognized issues. So number one is bias. So, the algorithms that bias against people of color and all those kind of things. So our answer for that at the moment is a committee. I hope that doesn't sound, but the committee's worked very well to oversee any AI ML projects that we come up with. And so it's a diverse committee, broad representation, and they can say, no, that's not going to work because that's not culturally appropriate or whatever. The other thing is, so that's the bias in the algorithms. The other thing is, although we like to think we have complete data, it is a bit of a circle. So to give you hopefully an easy one to understand, it's recently been said or claimed, or researchers have found, that poor sleep quality at, say, age 50 significantly increases your risk of dementia at age 75. I talked about biking. So if you bike 150 minutes a week, your chances of cardiovascular disease are down 30%. But we don't capture how many hours a week our patients bike, and we don't capture how many hours a night a patient sleeps. So when we talk about complete data, it's always going to be, you've got to bring in the science and the clinical research as well as just raw data. I think that's probably where the challenge is. Yeah.
Absolutely, absolutely. So, Doctor, how do you see the US CDI standard driving interoperability going into the future?
So again, like I said earlier, we like the US CDI. It's effectively, it's mandated for data exchange. So I do see it driving things forward. I do think it's a very good minimum data set. I've been on committees over the years where we come up with a minimum data set for diabetes or heart disease. And I can tell you within half an hour, we've got 200 elements that every clinician just has to have before they could possibly hope to manage that patient. So I want to praise the work that's been done with the US CDI, because it's a very good balance between, all sorts of data and the data that realistically need and will make a difference. I also like the process with US CDI where people are feeding in and we're getting a version 2 and a version 3. Just to explain from a software perspective, it is a little bit of it's unfortunate because, we've just spent a whole lot of time and effort building high quality, fantastic CCDA messages. So now I have to go back to the team and say, well, yeah, that was really good, but now we're doing this thing. So in some ways, our internal, it does kind of map the stress that hospitals and providers and payers are under. Last year or 2 years ago, it was CCDAs, now it's US CDI. But still, I think the US CDI is good, and I think we'll get there, and I think it will drive things forward.
Great. We have a question from the audience. It's quite long. I'll read it, and then you can respond however you'd like.
Sure.
So the audience member writes, no HIE system can make a patient's complete record available from all his/her providers. But if the patient is put at the center and controls copies of all his records from all his providers, we can have total interoperability. The patient can read and correct a record. If it contains wrong information, he can share it with any provider he sees, anytime, anywhere, and his provider can truly coordinate his care. The patient can also share his records with anyone he chooses, his providers, loved ones, caregivers, and researchers, including pharmacists working in precision medicine. Doesn't this beat HIE's hands down?
No. That's a very interesting question.
Yeah.
And, absolutely respect that view. And if what I can do is, rather than kind of taking on the specific points, if I describe where I think this is going and how it relates with HIE. So these questions are all totally valid and they're all good suggestions. Where we have come to in our thinking, and it's called the digital front door, what that means to make it straightforward, it's really a very enhanced patient portal. So, as everyone will tell, if you go to banking, you can go online and you can move billions of dollars around that 10 years ago you had to go into the office, into the bank, and the bank manager had to approve it and blah, blah, blah. Now you can do it on the internet, and it's all, in fact, you can do it on your phone. Similarly, if you want to book a flight, you can go to United Airlines, but you can go to book, you've got untold options, and then you can book a flight around the world and pay for it, and it's all done. And you never needed to talk to any pilots or managers or anyone, you did it yourself. Healthcare's been behind on that front, for sure. So what we're working on at the moment, and we have many customers, both in the US and outside the US, who are very interested, and it amounts to basically an enhanced patient portal, so the patients can go in there and have much more control over exactly the kind of things that with this question that is it Merle's asking there, but also perhaps if I just to explain why it's not enough, where we've got to why it's not enough purely if the patient moves things around. So while we totally support that, it's not enough. The problem is that you have this massive health system with complexity at every turn. So from patients often complain, how do I, just tell me, how do I've got a glioma, how do I access a neurosurgeon? Or just there's such a range of things. And in our discussions and surveys of patients, navigating the health system is often one of their biggest concerns. So we see all of the things that Merle's listed there, plus both assistance, both online help and a person, plus navigation. These are the services available in your part of Baltimore, wherever you're living. Here are the services that are available. Here's how the things they require. And where I think this will get to, and I think we're really well down the track, you can go online, or you can call a call center. You can say, I've got chest pain and it's going down my left arm. And they say, okay, there's a high chance that this is a heart attack. The nearest place is here and I'm calling the ambulance. So I think while I totally support, and we're trying everything we can to give patients much more control over their record, we are also trying to make that as part of the whole health system, because the patients by themselves, as with any other player in the system, it's not just the patient, unfortunately.
Yeah, good
Long
response.
answer. I hope that wasn't.
No, it was about as long as the question. So you were
okay.
Thank you, Doctor. So we just have a few minutes left, Dr. Hobson. This has been incredibly helpful. Why don't you just tell us how you see the next few years going forward in this area? Because I see a number of potential outcomes.
And as we said, I try to take the big picture, but I also try and see it from my world. I'm seeing increased clinical use of HIEs and clinical values. So that's a really good thing. The major clinical value from it is you suddenly have all about this patient. You don't have to spend an hour asking the patient everything, and then they go to the next provider in another hour while they ask everything all over again. So we can solve those kind of things. And I think clinicians, it's taken a while, but I definitely see plenty of studies show an increased impact. Another way this will evolve, related to that, is, for instance, I was reading the emergency medical services. So the EMT technician turns up on the street, there's a patient unconscious being hit by a car. They know nothing today, they know nothing about that patient. Surely, as soon as they can get access to that patient's identity, they should, and various states have done it, but go to the HIE, find it all out, and then as they come to hospital, bi-directional sharing of data all the way in. So where I'm going with that is there will be a number of really good, obvious use cases that HIEs can handle well that other systems can't. So number one, and it also combined with, as you said, sustainability. So the HIEs are much more sustainable. They'll have many more use cases. And maybe I'm being optimistic, too optimistic, but I think the federal interventions, the ONC, CMS, TEFCA, 21st century, I see those all positive. And so if we can just do them at a rate that we can keep up, I think the future's pretty bright. This will really make an impact on healthcare.
I think so too, actually, Dr. Hobson. I think the future is bright. I would say the future is complex but bright, if that makes sense. Yeah.
Correct.
So,
very
Dr. Hobson, thank you so much. This has been so useful, and it's cleared some things up for me as well. So thank you. You've been wonderful.
You're very welcome, Mark. It's been a real pleasure.
Excellent. Well, I want to thank you both for a fantastic session. We are now going to take another short break before we resume with our third session of the day, which will be a panel discussion starting at 2 p.m. Eastern Time on the future of consumer-facing digital health platforms and apps. We look forward to seeing you back here at 2 p.m. and thank you again.